Hello there, my name's Joseph Best. I'm an oral and maxillofacial surgeon in Waukesha, Wisconsin. And we're here today to talk about prescription pain control and dentistry. I will tell you this topic became very real to me as a practitioner about 8-9 years ago when I was reading a local paper in one of the communities where I practice. And there was this very tragic story about a mother describing the overdose death of her daughter. And her daughter became addicted to heroin. But her first introduction to opiates came from a prescription after she had her wisdom teeth out. And this girl came from a community where I practice, and so I was very interested to see, boy, could we have seen her in our practice? And I looked her name up in our computer system there, and I found out that I was the oral surgeon. And that really had a huge impact on me not just as a practitioner, but also as an educator, because I also teach pharmacology here at the dental school at Marquette University School of Dentistry. And so for me, this is not a new problem. And so I hope to describe to you how I see the prescription of analgesics for dentistry, and hopefully it'll help you in your practice. We'll start out with a case. This is Alan. He's a 57-year-old white male from Houston. He's a police officer, and he had some pretty extensive dental work done at the dentist and was prescribed Vicodin for pain. Well, Alan had a history of alcoholism, and he had always looked for the cure for a hangover. And he found that the leftover Vicodin from his dental pain episode was the perfect cure. And this perfect cure then ended up becoming a real problem for Alan, to the point that he was asking his dentist to do probably unnecessary dental work so that he could be prescribed some more pain medication. So Alan began abusing prescription pain medications, and he ultimately was getting prescriptions from pill mills, physicians that for a fee will prescribe you pretty much whatever you want. And he was spending $250 a day on pills, quit his job, and all of this started after postoperative pain for dental pain relief. I don't know about you, but I really don't want to be a part of these kinds of scenarios. And so I like this quote, was from the New England Journal of Medicine, and it was about opiate pain medications. And he says, "We know of no other medication routinely used for non-fatal conditions that kill patients so frequently." And the problem here is that patients who become addicted to these medications oftentimes switch to stronger injectable narcotic pain medications, and we're seeing increasing deaths in Wisconsin from heroin overdose. Another issue is a lot of patients, for whatever reason, for economic reasons, for social reasons, are not able to get dental treatment and are seeking emergency dental care in our emergency rooms. 18,000 visits to ED departments for dental pain, and these patients need to get some kind of care. And unfortunately, sometimes they're getting narcotic pain medications, and we need to figure out different ways to manage this. First of all, perhaps by getting these people hooked into more comprehensive care, but also perhaps using other strategies to manage their pain other than just narcotic pain medications. So first, I'd like to address a couple of myths about the opiate addiction problem. These are myths that are both in the public, but also myths that I hear from my fellow prescribers. First, illicit drugs are more dangerous than prescriptions. The fact of the matter is all opiates affect the brain the same way. All of these drugs can be abused, and all of these drugs can kill you at overdose doses. And so just because it's a prescribed medication does not mean it's necessarily safe. And if you look at the early problem with the opiate epidemic, with the dotted line on this slide, you can see there was this initial real jump in the number of overdoses from prescription drugs. Now later on, you can see this, there's a second wave that happens where as we got better at perhaps making these prescription drugs a little less easy to get, we're starting to see this jump in number of heroin overdoses. And now, unfortunately, we're on to the third wave, and that is these synthetic opiates. There is contraband synthetic opiates that are coming over the border. These are even marijuana that's been laced with fentanyl. This is a very, very potent, 100 times more potent than morphine, fentanyl, and because patients are used to taking a certain dose, they take this fentanyl, and sometimes it can lead to overdoses and deaths. Another myth is that this is just the bad kids that are taking these drugs, and the fact of the matter is there are no communities that are not affected by the current opiate crisis. It knows no socioeconomic, no religious, no ethnic differences. These are drugs that are affecting all of our communities, and so it doesn't matter what your practice setting is. This is something you need to be aware of and potentially maybe change your prescribing habits. And the other thing is that a myth is that people obtain these prescription painkillers on the street, like they're going onto Wisconsin Avenue and buying Vicodin. Well, that's actually not what's happening. Most of the prescription abuse are drugs that are either legally obtained by the doctor or drugs that are obtained from leftover medications from the grandmother's hip surgery, and there's leftover Vicodin, and an adolescent gets that out of the medicine cabinet, but not something that's actually being purchased on the street. And that, again, the 70.8% of the people misusing opiates got them or took them from a friend or a relative. And when you look at the data, it's very impressive how the source of these drugs, where it's coming from. And so one of the takeaways from today's talk is that it's the leftover medications that are the problem. And so when you're prescribing, we always have a tendency to prescribe to the worst outcome of a surgery. That's what we were trained to do. But really what we need to be doing is prescribing to the average rather than the worst case scenario. Because if we're always prescribing for the worst case scenario, you tend to have a lot of leftover pain medication after the surgery, and it's these leftover medication that end up being abused by various populations. And another myth, isn't heroin the problem? Well, yeah, heroin is becoming the bigger issue now for overdoses, but many of these patients addicted to heroin started out by abusing prescription pain medications first. And so what we want to do is have a smaller pool of these prescription pain medications that are out there being used and abused by the population. A few years back, a number of people at a number of different departments in the state got together to try to start addressing this problem. And I had established a relationship with former Attorney General Brad Schimel, who was the Waukesha County District Attorney, and came to our hospital and told the doctors 10, 15 years ago, look, we've got a problem. We need your help to try to get the prescription drug problem under control. And when he became Attorney General, he was part of getting this coalition together to try to address the problems. And his approach was to bring in people from the physician community, the dental community, the pharmacist community, the hospital associations, nursing associations, all together to come up with a strategy to try to get at solutions. So it's a multifaceted approach. You have law enforcement. I think law enforcement's figuring out that locking up people addicted to narcotics is not leading to long-term sobriety and good outcomes. It has been very tough to get at the dealer networks. Really, we need better treatment options for these patients and drug treatment programs that have actual impact. There are medication-assisted treatment programs with Suboxone and other medications that can be effective, but prevention, and that's what we're here to talk about today, and that is trying to prevent the daughter that I prescribed narcotic pain medications ending up addicted to heroin. And so what we can do is by prescribing to the average outcome. So there's clearly a role for both the medical and dental community, educating prescribers like we're doing today, changing the conversation about with our patients about what their expectations should be, what is the most effective way to manage their postoperative pain. And then there's a number of different guidelines that have been implemented, and the Dental Examining Board in Wisconsin was one of the first in the country to actually give very specific guidelines about how these drugs should be prescribed. But all of these affect, from that coalition when it started, we're already seeing a drop in the number of prescriptions that are being given in Wisconsin. And also what's interesting is it's having an effect on the manufacturers. The DEA now is reporting that manufacturers are seeing a 25% reduction in what they have to make. And so that's a good thing. So we're clearly the education of prescribers and education of the community is having effect. And so these are the kind of numbers we're seeing, these gradual reduction in how many opiates we're prescribing. And the PDMP, the Prescription Drug Database, is helping us understand exactly how we prescribe and also helping the state understand what impact their various programs is having. So if you look at where kind of dentistry lands, I was giving a talk on this topic, and I had a dentist say, really, isn't this a physician problem? Well, no, it's not. And if you look at, certainly physicians have their role, but we're right there. 9% of opiates prescribed are coming out of dental offices, and that's not a small number. And there are far fewer dentists than there are physicians. So just keep that in mind, that yes, this is a part of dentistry just like it is with medicine. But like with physicians, we are seeing a decrease in the numbers of prescription, and that's because of all of the tremendous education that's happened. I mean, it's very hard to pick up JADA these days without an article on opiates. I actually did that for my students. I laid out all the JADAs over the last year that had an article on opiates, and it was every single one. And so that's good, and it's getting to the root of the problem, but we can always do better. So recently there was a survey of oral surgeons in the country, and the results are very encouraging. Decrease in the number of refills, which you can't refill in Wisconsin, but in some states you can. Oxycodone prescriptions were down 31%. Vicodin prescriptions down 19%. And then also there's the Prescription Drug Monitoring Program has been very helpful. And one of the things when you're using that program, and you really need to get yourself onto that program and register, is that you can see where you fall as far as other prescribers with similar occupations. So I'm compared with other oral surgeons in that database, and I'm in the 7th percentile. And I like that. I want to be in the low end. If you find yourself in the 95th percentile, you need to rethink the way you're prescribing, because that is not where you want to be. You want to be at least below the 50th, the meridian there. You don't want to be the heavy prescriber, trust me, because what's likely to happen is you're probably going to get one of those fancy letters from the state, questioning your prescribing habits, and rightfully so, because there really isn't data to support that level of prescribing. So medical community also getting involved, both the Pharmacy Association, the nursing associations. At Marquette, we're teaching classes where we're giving, I actually have the former Attorney General, Brad Schimel, come in and talk to our class and talk about what law enforcement, and from the law enforcement end, what they're seeing. And we do some prescribing exercises that the students have to write prescriptions, and they understand what is going on. But unfortunately, all of this great effort has led to now patients that had been addicted to narcotic pain medications that were prescribed looking for other places to achieve and serve their habit, and that's led to overdoses increasing in heroin, fentanyl, and unfortunately meth now is re-establishing itself in the community, and we all know anybody who's looked in a meth addict's mouth knows the effects of that drug. So this number of opiate overdoses, it's a triple wave. You had started out with prescription narcotic pain medication, went to heroin, and now fentanyl. Other partners, you have the Department of Justice and they're making new rules for naloxone. I will tell you, I teach the medical emergency course here at the dental school, and I am now encouraging dentists, as part of their emergency kit in their office, to have nasal naloxone. Because unfortunately, there's a chance, somebody's coming in for a dental appointment, they want to help you with their pain control, and they take some narcotic pain medication and potentially can have issues. Having some naloxone there to reverse them is not a bad idea. Other partners, there's the Department of Justice Dose of Reality campaign. I will tell you, for me as a practitioner, the Dose of Reality campaign was outstanding as far as educating patients to understand the risks. And so I will almost routinely, on a daily basis, have parents refusing the 5 tablets of Vicodin I want to prescribe their child because they just want nothing to do with it. And that's great. It's awesome because it makes it very easy for me to do and not prescribe and break the habits that we all have of prescribing narcotic pain medications. And so that public education has been extremely helpful. And the HOPE legislation and legislation that's designed to get at better treatment options for patients, getting primary care physicians involved with Suboxone treatment. My sister, who's a family practitioner in Howard's Grove, was one of the first family practitioners to get approval to provide Suboxone treatment for patients. And so, because frankly, there aren't enough behavioral scientists, there are not enough addiction medicine physicians to treat all these patients. So primary care are getting involved. What can we as dentists do in our practice to be part of the solution rather than part of the problem? First of all, I think we have to understand pain better. I think we have to get very comfortable having frank discussions with our patients about addiction and risks. We need to get comfortable using the PDMP. And I'll tell you, I've used a lot of programs for the state. And sometimes, no offense to anyone, they're not all that easy to use. But the PDMP is an outstanding program. It really is extremely easy to use. You can sign on very quickly. Looking up a patient is very rapid, and the data that you can pull out of there, I find is useful, and it's easy to see and work with. And then we have to really get a clear understanding as dentists what NSAIDs are, how they work, and how they're probably better for treating dental pain, and then understanding long-acting local anesthetics and how those can be used. So let's start out with a case. This is the kind of case I think that all of us have seen in our practice. John's a 66-year-old male. He comes in this morning. You completed an endodontic treatment on number 8. He comes back to your office later that day in severe pain. He is asking for some of the strong stuff, doc. This Advil is not going to cut it. What's happening here? What caused this bad outcome after some treatment? And is there ways, if we're smart about how we prescribe things, can we prevent that kind of problem? So one of the things we have to understand, and I think I always see dentists as pain specialists because we have to deal with this all the time. And so you have to develop good strategies in your office to understand the basic science and to have smart ways of treating pain. So we all know that it's highly variable. There's a strong emotional component to pain, and the complex neurologic pathways that are involved with pain are far over the pay grade of a simple guy from Manitowoc. All right? But there are some things that I think that are not so complex that are pretty easy to understand. And that is that what's going on at the apex of John's tooth, where that root canal was done, is that when you do that, when you're doing the root canal, you're pushing stuff out that apex, you are going to get inflammation at the apex of that tooth. And you're going to get the release of all these pro-inflammatory cytokines, and these cytokines change the physiology of the nerves, the free nerve endings that are in that area. And it's these pro-inflammatory cytokines that are should be the target of our pain control strategies. So why does this matter? Well, for John, these inflammatory mediators are changing the nerves. They're activating and sensitizing the free nerve endings, and they're increasing spontaneous activity. And I know it's hard to look at an action potential. I mean, no one wants to look back in physiology with any fondness, except for physiologists, of course. But one of the things that happens is that you all remember the all or none principle. If you activate a nerve and you hit threshold, you are going to get nerve response. Well, we all think of threshold as this fixed thing. Well, it's not fixed. It changes. And when you have these nerves that are bathed in pro-inflammatory cytokines, you start to actually see changes in the way the nerves behave. And you get change of threshold closer to resting membrane potential. And what that does is it produces spontaneous pain. And so when that happens, you end up with a diagnosis of hyperalgesia, meaning you have this tissue that is, the nerve is angry, it is firing spontaneously, and the patient is in pain. So the key thing to remember is dental pain is inflammatory pain. It always has been, it always will be. And so the key to managing dental pain is in the name of the drug, anti-inflammatories, because of the nature of dental pain. And so if we develop strategies that utilize and target inflammation, we're going to get better outcomes. So when you look at what do we have out there to use, you're looking at your non-opiate analgesics, which can be your salicylates, acetaminophen, and your NSAIDs. And then you have your opiates. You have agonists, mixed agonists, antagonists, and we used to classically think as opiates centrally acting, NSAIDs peripherally acting, but it's really not that simple. And really, the take-home message is that the NSAIDs are going to be your number one and primary tool for managing postoperative dental pain. So why are they so good? Well, first of all, they have excellent oral efficacy. They have relatively low incidence of side effects. There's no abuse potential. We do not have patients out on Wisconsin Avenue trying to score some Advil. It just does not happen. And so that's a good thing. And they're cheap. They're relatively inexpensive for the patients to purchase. And they are absolutely the first line of drug for postoperative dental pain. Now, how do these drugs work? Fairly straightforward mechanism. When you produce tissue injury, you get the release of phospholipids that get broken down to arachidonic acid. And the arachidonic acid is further broken down to the prostaglandins. And the enzyme that does that is called cyclooxygenase. And cyclooxygenase is the target of the anti-inflammatories they use. Now, just keep in mind, when you block cyclooxygenase, the arachidonic acid doesn't just disappear. It actually gets broken down through a lipoxygenase pathway to the leukotrienes. And that's important to remember for asthmatic patients, because there are a lot of asthmatics that have a leukotriene kind of mediated asthma, where if you put people on long-term anti-inflammatories, you can exacerbate their asthma symptoms because of the leukotrienes. So one thing to also remember is that all cyclooxygenases are not created equal. There are different isoforms of that enzyme. COX-1, cyclooxygenase 1, is the ubiquitous form. It's actually involved with maintaining your gut. It's involved with in kidney function. It's involved with your platelet aggregation. And so when you look at the bad side effects of chronic anti-inflammatory use, it's because of the blocking of COX-1. COX-2 is the inducible form. That's the one that's expressed in cells in response to trauma. It has a role in acute inflammation, and that's the one we want to target. So pharmaceutical companies have spent billions, and that is with a B, to develop drugs that are very COX-2 selective with mixed results, but that will continue to happen. just keep in mind that you do already have very inexpensive anti-inflammatories available to you, like ibuprofen, that blocks COX-2 quite effectively. Now, when we look at anti-inflammatories, and I'm including the salicylates here, and you look at which ones they block better, COX-1 or COX-2, aspirin is actually a drug better at blocking COX-1 than it is COX-2. So aspirin as a primary pain control for dental pain doesn't make any sense. Now, when you go down the line, you can see a lot of these drugs kind of even, Steven. But when you get to ibuprofen and atodolac, Lodine, those drugs are actually better at blocking COX-2 than COX-1. And that's what makes them more effective with fewer side effects. And then you get to the Coxib family, which are the best. They block almost exclusively COX-2 with very little COX-1 activity and therefore have fewer side effects. Now, the thing to remember here is when you're doing acute pain dosing for 3, 4 days, 5 days, a lot of this doesn't matter that much. You're not going to destroy somebody's kidney with 3 or 4 days of ibuprofen. You're not going to cause major platelet issues with you providing Advil for 3 or 4 days. You're not going to cause problems with gut mucosa for just a few days of an anti-inflammatory. It's only when you start prescribing these drugs for months at a time, like somebody who has rheumatoid arthritis, where they're taking anti-inflammatories for long periods of time, where you start to see major health side effects of these medications. Now, COX-2 selective agents are going to continue to be developed. They're likely to have fewer GI, platelet, and renal effects. They are expensive. And so, and these drugs are going to keep coming onto the market. And I would encourage you as a practitioner, because you're going to be the subject of the marketing. I would just ask you to ask one question when these newer, fancy, whiz-bang, new anti-inflammatories come out. Are they any better than the cheaper stuff that my patient can buy in a jug this big at Costco for 12 bucks? Because that's the key. For acute dosing, these drugs are not going to provide really significant improvement in your pain control, but just cost the patient more. And also we have the problems with some of these medications causing increased stroke risk and MI. So here's the list of all these different COX-2 that have been introduced to the market. We all know Vioxx. I used to give lectures. I gave lectures for the pharmaceutical company that produced Vioxx online or it was on the telephone, and they would pay me quite nicely to do that. All right, but I kept telling the people on the phone that, well, Vioxx is very nice, but it's not any better than ibuprofen for acute pain dosing. And for some reason, they stopped asking me to give the lectures. I don't know. But anyway, so I would just going down the list, these drugs are excellent. I think that they should be part of your armamentarium. Drugs like Celebrex, Meloxicam. These are drugs that can be used if you need long-term anti-inflammatories. For example, if you're treating somebody with TMD, where you really need to get the inflammation under control in the joint and you plan to have for them to be on weeks and weeks of anti-inflammatories, then these drugs make sense. But for acute pain dosing for a episodic dental pain, really they don't have any advantage over a drug like ibuprofen. Keep in mind there is a COX-3, and this very well might be the site of acetaminophen activity. We've really never known for many years about how does acetaminophen work. COX-3 is involved with a fever mechanism, and it's very likely the analgesia that's provided by Tylenol is probably through the COX-3 enzyme. Now, I include the salicylates here, just talking about individual drug families. Just to be complete, again, I would not recommend this as an acute anti-inflammatory to use in your practice. And it's because of all the side effects. And when you look at these side effects and adverse reactions you can have from these drugs, remember, it's usually not from acute dosing. It's from long-term dosing. So things like inhibition of platelet function, GI upset, renal issues, liver issues, that's usually from longer-term anti-inflammatory use like aspirin. But But when we talk about what drugs are really the workhorses for dentists, we're talking the propionic acids. And in particular, drugs like ibuprofen, ketoprofen, naproxen. These are drugs that are extremely effective, have fairly small risk of side effects, and a very, what we call, wide therapeutic range. And so I would encourage you to exploit these drugs to utilize to manage your patient's pain. But keep in mind, if given for chronic periods of time, they will have side effects. So if you have somebody that's taken Advil every day of their life, they will have side effects. You're going to have GI issues. You will have issues with your kidney and potential problems with bleeding. These are not drugs that are really designed to be taken every day. And so if you have a patient who says they take ibuprofen every day, you need to talk to them about that. That if you really need to be on those medications, you need to talk to your physician about perhaps being put on one of the more COX-2 selective agents like a Celebrex or meloxicam. The indoles are another family, Totolac, Lodine. This is a drug that we actually did some of the studies on that, looking in a third molar pain model. Very effective, but again, it doesn't offer really any huge advantage over ibuprofen unless the cost comes down. And right now it's more expensive than ibuprofen, so it doesn't make a lot of sense. Then there's Ketorolac. The thing that's nice about Ketorolac, it's one of the only, now there are a few others, but one of the only IV or intravenous anti-inflammatories that we have. And so Toradol has a huge advantage to be able to be given to patients through an IV. So when I do a set of wisdom teeth, the first drug I'm giving in an IV sedation is I'm giving Toradol. I want that anti-inflammatory on board before we even start surgery. But I don't want them to have ibuprofen in their stomach before I'm doing an anesthesia. So that's why a drug like this makes sense. As an oral drug, it's just too expensive when ibuprofen is going to provide the same therapeutic benefit for a lot cheaper. And remember, Ketorolac is black box for patients over the age of 65 because of elevated issues of GI bleeds. Tylenol, acetaminophen, this is again, it's not a particularly good anti-inflammatory, probably works through a COX-3 mechanism, good antipyretic, does provide some analgesia. And there is some data to show when combined with other anti-inflammatories, there is some synergistic effect. So the idea of combining ibuprofen with Tylenol has therapeutic merit. And so I would encourage you to consider that. Now we get to the opiates, and there's the laundry list of opiates that are available. And I tried to put them it gets more serious the further you go down this list. And so codeine and hydrocodone, I would say, are the most that I would encourage you to prescribe. I would avoid oxycodone. There's clearly evidence now to show that that medication has some fairly significant addiction issues. Then you get into the mixed agonist antagonist, and tramadol is an interesting drug, and I'll talk a little bit about that one. When we look at the mechanism of action, these act through opiate receptors, both in the brain and the spinal cord. And there actually is also opiate receptors on inflammatory cells. So it actually inhibits inflammatory cells, which can lead to issues of infection. But the key thing here is that there are different receptors, and which receptors are affected can contribute to what kind of side effects you have. And so what we're seeing now is people trying to develop designer opiates that maybe don't have as much mu effect, but maybe are more kappa selective and can provide more analgesia without all the euphoria and potential addiction issues. Tramadol is an interesting drug. It's a weak opiate agonist, but also some serotonin and norepinephrine reuptake inhibitor activity. And there's been third molar pain models that have shown that it's just as effective as Tylenol number 3 for controlling postoperative pain. Now, I used to actually teach that this drug had low addiction potential, but I actually had a dentist come up to me while I was giving a lecture in Wausau, and the dentist said that they have a problem with their over-the-road truck drivers abusing tramadol because it's not tested in their drug testing. And so it's a weak opiate, but just like all opiates, has some addiction potential, but it is available to you. I will tell you, this is the drug that is good for the patient that is allergic to every pain medication you know how to prescribe. They're allergic to all the anti-inflammatories you know how to prescribe. They're allergic to any narcotic pain medication. They're allergic to dairy, non-dairy, human tears. They're allergic to everything. And so this is a drug for them. It works quite effectively, and I like it for that. It seems to be pretty well tolerated. You have the mixed agonist-antagonists like Talwin. We used to use this a fair amount. It isn't a drug you see used very frequently anymore, but maybe something we should be rethinking. In fact, Talwin NX, which actually has naloxone in it. And the advantage of these pain medications that have naloxone mixed into it is they're very difficult for abusers to inject or to take through the nasal, through inhalation. Because the naloxone is removed with a first pass effect when you take it orally, and it allows the pentosacine to work. But if you try to take it other ways that bypasses the GI tract, the naloxone will be there and they'll get no high out of it. And that's sort of the theory behind Suboxone too. And then obviously you have the antagonists, naloxone and naltrexone. So how do we dose these things? We know that the higher the doses means the higher risk for potential abuse. And it's measured in something that's called morphine milligram equivalents, MME. So when you look on the PDMP, there's going to be this red line, and that red line is going to be at 50 MME. Because we know when patients are prescribed over that 15 MME, their risk for potential addiction issues goes up. And so what you want to look for when you're checking the PDMP, if patients are over that line, you definitely do not want to get into prescribing these patients more narcotic pain medication. They already have the medications prescribed. So you want to keep yourself always below this 50 MME. So how much is 50 MME? So when you're talking about a drug like hydrocodone, that's 50 milligrams of hydrocodone, 10 tablets of Vicodin 5x300s in one day. When you go to oxycodone, that's 33 milligrams. Which is basically 7 tabs of the oxycodone in one day. So this is your benchmark. You've got to keep yourself below these kinds of doses because that will keep you out of getting the nasty letter from the PDMP folks. And one thing that's very, very clear in studies is the danger of prescribing these drugs to adolescents. This is a study that took 15,000 teenagers and young adults, received initial opiate prescription from their dentist in 2015. 7% had additional opiate prescribed within a year, and almost 6% were diagnosed with opiate abuse disorder within that time. These are crazy numbers. That's very scary numbers. That should scare us, all right? And so when I see that data, it makes me really rethink how I'm practicing. Interestingly, for those who did not receive an opiate prescription from their dentist, only 0.1% got another opiate prescription, and only 0.4% were diagnosed with opiate abuse disorder. So this is a dramatic difference. We're talking about 6% versus 0.4%. That is, those kind of numbers are scary. I know the ADA had some issues with this study, but I'll tell you, I've read this study. And I think that we should really seriously be very careful prescribing these drugs to adolescents because there's a high risk. And then there's always this question I get from dentists: aren't they more potent? Well, let's look at the data. Do opiates provide more analgesia than anti-inflammatories in dental pain models? 2 evidence-based Cochrane systematic reviews of the literature. This is 45,000 patients. And what they found was NSAIDs were remarkably effective at controlling postoperative pain, and opiate analgesics were associated with high incidence of adverse side effects. You know, the call in the middle of the night that Johnny's vomiting from the narcotic pain medication, constipation, other issues. More evidence? You need some more? Another systematic review of analgesic medications. First conclusion, opiates are not the most effective for acute pain medication associated with higher adverse reactions. Okay? Second conclusion, relief of postoperative pain with from dental pain with NSAIDs, with or without acetaminophen, equal or superior to the opiate-containing medications. So I think we have to ask ourselves, with the evidence that's available, why do we prescribe opiates at all? Well, I'll tell you, for me, it is very hard to break a practice behavior. This is a pattern. I was trained to do this. And so that is a hard thing to break, and we don't want our patients to have pain. But when you really look at the data, and when you start challenging yourself, and like I have done over the last 10 years, is prescribing many full bony third molar cases, prescribing no anti-inflammatories, and not having problems, you start to realize maybe we've been doing it wrong all along. And there's also this image in our society that, you know, you have the drug enforcement guys with their blue blazers with the yellow letters on the back. These drugs must be so potent. Well, the fact of the matter is you need to look at the data. You need to look at what really is the truth. And the truth is, when patients don't know what they're taking, anti-inflammatories are incredibly effective at controlling postoperative pain. And there's this placebo response with prescribing these medications. And again, we have a tendency, and we're trained, to prescribe to the worst outcome rather than the usual outcome. And then the patient expectation and demand. That has gotten better. And I'll give the state credit, because their Dose of Reality campaign has done wonders to change patient expectation and demand. So what's the strategy? Here's the strategy that I teach our students here at the school, and what I would encourage you to consider. For mild pain, you're looking at over-the-counter anti-inflammatory prescribing. You're looking at ibuprofen, naproxen. If you got the person who just has to have a prescription, a Totolac. You know, they don't know what that is, and it sounds like it must be good, right? It was on a prescription. It must be more potent, so prescribe it. Moderate pain, all we're doing is increasing the doses. And then when you get to severe pain, you're maximizing out your anti-inflammatory doses, and you can potentially give small amounts, 5 tablets, less, of hydrocodone or codeine. Now, one of the other strategies to consider if you're having, let's say you have the patient who's having difficulty in having pain, is to cut back the dose so that the patients can take things more frequently. If I'm having difficulty with a patient controlling pain, I like to go to the lowest doses so they can take things more frequently, and then adding Tylenol in between the anti-inflammatory doses so the patients literally can take something every 2 hours. So they take 400 milligrams of ibuprofen, 2 hours later take over-the-counter Tylenol, 2 hours later take ibuprofen, and ping-pong back and forth between those two. That combined with some topical anesthetics like benzocaine, your Oragels, your Ambisols, where you can apply it to the socket or exposed pulp to get the patients more comfortable. That's a good strategy rather than flogging them with opiate analgesics. And I emphasize this with students. The least effective medication ever prescribed to a patient is a medication a patient can't afford. And so you need to understand what these things cost. And so if you look at drugs like naproxen and ibuprofen, they're very, very cheap for a patient to be able to get the analgesic they need for postoperative pain. When you get into these whiz-bang, new fancy, newfangled anti-inflammatories, which in acute pain studies have not been shown to be any more effective than the cheap stuff, then maybe rethink prescribing some of these more expensive anti-inflammatories. And especially, and this is not going to stop. Drug companies are very interested in developing, especially with the opiate prescription crisis, there are lots of drug companies trying to develop new drugs that can be used for chronic pain. And they will market those drugs to dentists for acute pain as well. And all you simply have to ask, when the attractive lady or guy comes by the office with the bagels and coffee and tries to encourage you to prescribe their drug, take the bagels, take the coffee, I have no problem with that, but ask them one question. Do you have a study that shows that your new whiz-bang anti-inflammatory is any better than ibuprofen? Because if they don't, and they're not going to have that study, what they're going to tell you is make sure you try the hummus. It's very good. They're not, because they don't do that study. Because that's, they already know the results. The results are it's not going to be any more effective. It'll be effective, but it'll be just as effective as much more inexpensive drugs that you can use for your patients. So what's new for analgesia for dentistry is that there are always going to be new drugs coming down the pike. But again, I would have a discerning eye for what is real and what is just marketing. Caffeine as an additive is nothing actually very new. That we've known that caffeine, when added to analgesics, can improve analgesic performance, especially with some of the adolescents today who take in a fairly significant daily dose of caffeine. We may consider, especially patients who have had some surgery and maybe their diet and what they take in has changed. Maybe they just need to have some coffee mixed in with their analgesic or whatever Monster or whatever they're drinking, and that can potentially help as well. And then what I think is going to be very important and will be part of your practice very soon is the ultra-long acting local anesthesia. And that's the bupivacaine impregnated liposomes. So what drug manufacturers have done is they take these liposomes, and inside the liposome is bupivacaine. And so what you can imagine when you're injecting this, there are all these little clusters of liposomes with bupivacaine in them. And then there's bupivacaine surrounding all of this. So you give the block, the bupivacaine provides anesthesia. And then over time, these liposomes will break down and release more bupivacaine. And so these have been shown to give up to 96 hours straight of anesthesia. And it's being used in chronic pain for patients with sciatica, patients with low back pain, and neuralgias of various sorts. And this is now currently being studied as something to be used in dentistry. So there's ongoing clinical investigation and efficacy for third molar extractions. Keep in mind, all right, that this is not approved as a block. It's actually used as an infiltration. But I think this shows tremendous promise. I have not incorporated it in my own practice because I don't want to experiment on my patients. I'm waiting for the data to come out from these large clinical studies to look at the effectiveness of the medication. The other issue is the drug is expensive. It's like $250 for a vial of this stuff, and there really is no way to really kind of get reimbursed for the cost of the medication. Another thing that and anybody who's seen me talk over the years, I am absolutely a zealot about, is preemptive analgesia. And this concept is preventing the formation of those inflammatory cytokines at the apex of the tooth. So if we go back to the patient I started with, the gentleman who had a root canal and then came back in pain, the way to prevent that from happening is prescribing anti-inflammatories before you instrument that canal, so that by doing so, you prevent the formation of pro-inflammatory cytokines and you prevent this snowballing of pain postoperatively. And bleeding is not an issue. I give Toradol to every third molar patient I have, and I have patients take anti-inflammatories for at least 48 hours after surgery. Bleeding is not, if bleeding was a problem, I would be having to deal with bleeders every day of my life. It's not an issue, not in the short term. So preemptive analgesia is significant evidence. So I don't just make this stuff up in my garage. There's a legion of evidence, both in the medical and dental literature, about the effectiveness of preemptively treating with analgesics. And this is by prescribing NSAIDs prior to surgery and or steroids. So let's look at the data. What does the data show? So this is an example of what we see with different treatment strategies. So the way I was trained, right, you numb somebody up, you take out their wisdom teeth, and when they start to have pain, take your pain medication. And that's the spiked tracing there. And there you can see the patient has this big spike of pain. They take their pain medication and their pain slowly goes down. And that's bad. That's the roller coaster of pain we want to avoid. That's the example I gave you with the gentleman who had the root canal on number 8. But if we give the patient 800 milligrams of ibuprofen an hour before the surgery, an hour before the pulp extirpation, an hour before the third molar extractions, you don't get that spike. That's the second tracing there, a little bit lower down. And if we combine the preoperative anti-inflammatory with a long-acting local anesthetic, and this data is zeroed to when the numbness wears off. So it doesn't matter if they've had a short-acting or long-acting local anesthetic. If you give a long-acting local anesthetic as well, you never see a spike. And for me, this is what I want to see with my patients. So you want to prescribe anti-inflammatories prior to some kind of surgical trauma. You want to provide long-acting local anesthetics, and you will get better post-operative pain control, guaranteed. So what we have to do today to get better at this is we have to utilize NSAIDs in our practice, both as a primary analgesic and as in preemptive strategies. We need to use the PDMP. It's there for us. It's a very effective program. We need to use preemptive strategies, as I said, long-acting local anesthetics, drugs like Marcaine, or potentially the liposome impregnated bupivacaines. And always consider, when you're having pain problems, whether things have changed. Because you might have a situation where you just need to come up with a different strategy for managing the patient's pain.